Okay, welcome everyone to today's RettSyndrome.org RettEd webcast. This is Paige Nuez. I'm Director of Family Empowerment at RettSyndrome.org, and I'm also proud mom to Katie, our beautiful 15-year-old high school freshman who also has Rett syndrome. On behalf of our board of directors and team, we're so pleased to bring you today's webinar. You and your children are so important to us, and we believe in supporting your everyday health and well-being on this road while we simultaneously and aggressively pursue research towards real treatments, interventions, and ultimately a cure for Rett syndrome. If you would, you can visit rettsyndrome.org/RettEd, RettEd, to see our calendar of upcoming monthly webinars and topics, and you can access past recordings of past webcasts. If there's a topic of interest to you that you don't see on our calendar for this year, please feel free to email me and we will do what we can to secure an expert speaker and bring your topic of interest to life for everybody in the U.S. and around the world. Before we begin, I'd like to share some brief tech points on how GoToWebinar operates if this is your first time with us. The audio feed is open only for our presenters, so you don't have to worry about your background noise interfering with the presentation. If you look to the upper right corner of your screen, you'll see a control panel window. We invite you to type your questions or comments in the question field throughout the presentation, and we'll answer them at the end of the slide presentation. If we don't get to your question during today's webinar, we will work with our presenter to get all write-in questions answered, and we'll post the QA document to our RettEd webpage once completed. If the control panel window is distracting to you or obscures the slideshow presentation, you can minimize or move the window at any time, and then you can expand it if you wish to submit a question. The next point is the session is being recorded today, and we will post a link of the recording along with the QA document again to the RettEd webpage so you can listen again or share that link with others in your child's life who may be interested in this topic. If you're having trouble hearing, please check and turn up the volume on your phone or device. And if you have any technical issues that continue to plague you, go ahead and type them into the question box, and myself or Jackie Ventura from RettSyndrome.org will help you troubleshoot those issues, but hopefully everyone is settled in and comfortable with the technology. So before I introduce our speaker, I'd like to quickly highlight a newly launched page on our website, especially dedicated to families of women with Rett syndrome. Here you'll find a growing hub of helpful resources, family stories, and connectivity to guide your way in this journey to adulthood. You can find it at rettsyndrome.org under the For Families section called Adults with Rett Syndrome. I'll paste the URL into the chat box of the control panel, and we hope you take the time to visit, explore, and contribute your own experiences, and we'll reveal content on that page as we continue to collect from our community of experts. So now I'd like to introduce Jane Lane, registered nurse and clinical research coordinator at the University of Alabama Birmingham Rett Clinic at the Civitan International Research Center. Over the course of her tenure at UAB, Jane has co-authored many papers on the natural history of Rett syndrome. She's been involved in Rett syndrome clinical research and clinical trials. She's spoken at countless conferences and workshops on Rett syndrome worldwide, is a respected consultant and advisor to rettsyndrome.org, is a very good friend to all of us, and is recognized for her particular interest in family education and management of the issues of womanhood encountered from puberty through menopause in Rett syndrome. So I know we all give you a very big warm welcome, Jane, and if you're ready, I will go ahead and turn the screen over to you now. And once you get your slides up, you can go ahead and begin your presentation. Thank you for being with us today.
Yes, my pleasure, Paige. Let's see, let me, sorry guys, this is going to take me, even though Paige went over this with me on Friday, this is always something that gives me pause.
That's fine.
that good? Does that look good?
We see it.
Okay, excellent. Well, I am very pleased to have been asked to talk with you today, and I'm humbled by the introduction that Paige gave, and I'm just delighted that so many of you found time to be present today, and I hope that this is informative as we go through what womanhood means in Rett syndrome, and it's womanhood from puberty to menopause. And a rite of passage isn't a misspelling. I do find that, it's my opinion that allowing this passage to occur from puberty to menopause is your daughter's right. So, it's not moving. Hold on. My screen is not wanting to progress. Hold on. Paige, let's see. That. Here we go. Now maybe. So puberty, your approach to puberty or your ideas about puberty vary quite a bit, and it's all about your perspective as to what your approach and thoughts about puberty are in your daughter. So you have families on one side that are like, oh my gosh, I hope it never happens. And then you have physicians and clinicians on the other side that say, no, we want it to happen, but we want it to happen just right on time, not too early and not too late, and not with any problems that might interfere with that. And I'm always impressed with the fear that parents tell me they're having about thinking about puberty in their daughters, and even the very young, newly diagnosed. Often, it's one of the first questions out of the gate once we've answered the ones about clinical severity and mutations and other things. It's one of their top questions about how to prepare. And I'm always wondering why is it that the idea frightens us all so? And these are sort of a culmination of what I've learned over the 25 years of doing this, or 20 years of doing this, and you can tell me more. But I do think that it's the worry of the unknown. Even though as women we've gone through these steps before, and the situation, it's still different when it's your children. And if you have children who don't have Rett syndrome, you probably had the same worry at that time. Parents worry about pain and discomfort and how they're going to manage that, and how will they know what they should, how they should anticipate that. There are misperceptions about the ages of onset in Rett syndrome. There's the worry of new onset or worsening of seizures. How will hygiene be handled? And then social taboos that may affect paternal care, either ethnic or types, or even, just that the father is all of a sudden worried about, how he will be perceived as changing diapers or toileting or caring for his daughter who now is menstruating. And the fear that another specialist might be needed. It might be a reminder of our own ages and finite lives. And then, of course, the fear that womanhood brings the fear of abuse. But I like to say, and this is one of my favorite quotes from on the topic and most anything, where the fear of the unknown is paralyzing us, and it's one from Kofi Annan, and that is, knowledge is power and the information is liberating. So on that note, the things that we'll be talking about today is puberty and menarche, some of the natural history study data from that gives us information about puberty, ideas about menstrual management, the implications of seizures with in puberty or menopause, health maintenance ideas and advice, and then some unfortunate facts on abuse. We'll start out with puberty and menarche. So first, the first premise of today, the first idea is that puberty and menstruation are normal functions. And so in all of the things that you face as parents of children with Rett syndrome that are abnormal, things that you have to worry about that are off kilter, this is normal. This is what we want to happen. And the process is actually hormone driven, and so the structures in the brain, the pituitary glands and the hypothalamus, specifically the hypothalamus produces gonadotrophin releasing hormone, and then the pituitary gland is stimulated to make luteinizing and follicle stimulating hormones, and then the ovaries make estrogen, and the equivalent to that in males are the testicles that make testosterone. But when the ovaries and make estrogen and all of these upstream structures do what they are supposed to do, then voila, we have a lovely young lady. There are changes that you can anticipate with puberty. Some of the body changes are listed here, and some of the first thing that you might notice, even in the very young, is underarm odor, and that doesn't necessarily mean that things are imminent, but it certainly may be the first sign that you notice. There will also be a growth spurt. Breasts begin to develop and the hips widen. Pubic, underarm, and leg hair thickens and darken. The skin and hair might become more oily, and acne may begin to appear. And then very close to the time of menstruation, you might see a clear, odorless vaginal discharge. And then there are comfort and mood changes that also accompany or might accompany puberty. Cramping, mood swings, irritability, and fatigue might even occur prior to menarche, and menarche being the beginning or periods, basically. Physicians and clinicians refer to development in stages called Tanner stages, and they're numbered and described as 1 through 5 as Roman numerals. So if you read the literature, or if you look at the medical charts, they may say Tanner stage, child in Tanner stage 1 or 4 or anything in between. And the diagram that I'm showing you roughly corresponds to what the changes that you see, and they may not be concordant. So you may have breast development 2 and pubic hair 3 and the such. And we'll see later on this diagram again, and I'll bring it into context. The menstrual cycle actually there are a lot of things going on in the background. And you'll see, I love this diagram because it does show everything that's going on from the days of the month listed below, the day of the menstrual cycle. And then I'll start at the top. These are the changes that occur in the ovaries with the unfertilized egg, the follicle being that's in that ovary from birth. A girl is born with all of the the eggs that she will ever have, and they mature as follicles and are released at ovulation, which occurs sometime in the middle of the cycle. And this is all things, this is in the perfect world, and with a perfect 28-day cycle. Body temperature fluctuates greatly, greatly, a degree centigrade, but it fluctuates all through the cycle. And those of you who, if you've been trying to get pregnant and you take your basal temperature, will have recorded this and know this to be true. The next section below that, look at the 4 hormones that are part that drive some of this, that drive the system. The blue one is estrogen, the blue line, and you can see it rises right before ovulation and then peters off. Progesterone is quite low at the beginning of ovulation or through until ovulation, and then spikes during the luteal phase. Follicle stimulating hormone is in red, and luteinizing hormone is in green. And then this demonstrates what happens to the lining of the uterus also during the phase of during the course of the month, with the very thick lining at the beginning of menstruation that then sloughs. It's a very rich environment at this time, and then the lining breaks down as the month goes along, and then begins again and is sloughed off completely during menstruation as it goes along. We'll also look at this diagram in a bit longer as well, a bit later. So there are variants that can occur in development and that can either prevent menstruation and puberty from occurring, or could interrupt that down throughout life. And Marge Simpson is going to help us identify where those problems might occur. So they could occur in the brain with the hypothalamus or the pituitary, maybe in the thyroid, in the adrenal glands, the ovaries, or even the vagina or the uterus. So in this regard, no periods is not necessarily a good thing, but it's also not your job to figure out what's going on. That would be a terrible burden to try to figure out. And so that's why you have to feel comfortable talking with some sort of specialist, whether that is a pediatrician or an adolescent medicine nurse practitioner or physician or gynecologist. Many of you may know about the Natural History Study, which is an NIH-funded study of the natural history of Rett syndrome and Rett-related disorders that was awarded in 2004 to a few sites, 3 sites to begin with. The first iteration expanded to 4, and now we have 15 sites across the U.S. that are enrolling in this very important study of the natural history of Rett syndrome and Rett-related disorders, including MECP2 duplication, CDKL5, and FOXP1 disorders. And so if you are, many of the important discoveries and information in today's presentation, as well as about other medical issues such as seizures and scoliosis and bone health, and all of these things have come out of the important work that is made possible by those in this country who have enrolled in the study. And I encourage you to ask about the natural history study and participate by enrolling your daughter of all ages. It's just such important. The work that's coming out of this is very important. So one of the things that one of the first things we described out of this study of the natural history was the developmental development of secondary sex characteristics and maturation in girls with Rett syndrome. And so in this table, you will see the three characteristics of pubic hair, breast development, and menstruation. And then in the two columns, you'll see the age of onset, first in Rett syndrome, and then compared to the U.S. norms. And so just as a quick glance across, you can see that pubic hair is slightly behind that of the U.S. norms in typical children. Breast development also a little bit behind the typical U.S. norms, but not quite as behind. And then menstruation is pretty close to the typical population, general population, for the most part. And these are based on data summarized and published by a young medical student here at UAB, and who has wrote and published a very important paper on this topic. We also found in the analysis of these data some other important and timeline trends in Rett syndrome. You'll notice first that pubic hair development on average in Rett syndrome occurred about 9 years, but there were a significant number, almost a fourth of those individuals developed pubic hair prematurely, before age 8. But yet the pubic hair development to menstruation timeline is still it's 4.5 years out on average. So just because pubic hair develops doesn't mean that that menstruation is critically imminent. Same thing with breast development on average occurs at 9.3 years, and that's if you remember back on that Tanner stage diagram, breast development and pubic hair development is considered Tanner stage 2. And so Tanner stage 2 breast development on average occurred at 9.3 years. 25% though reached that at prematurely. 4% though developed that after age 13, and which would be considered delayed. But again, the trend from breast development to menstruation, the timeline is still some years out. So Tanner 2 to menstruation would still be almost 4 years after. And then menstruation on average occurred at age 13. 13% would occur before what's considered prematurely before age 11.2, and still a significant number after age 16, which would be considered delayed. And I've highlighted here that important timeline that the appearance of pubic hair and breast development still would suggest that menstruation are years down the road. So if we look at that timeline comparison between the U.S. population and Rett population, just looking at this diagram again, so the timeline from Tanner 2 to 4 in the general population is about 3 years, and in Rett syndrome is closer to 4, almost 4.5 years. We found other puberty onset predictors in that same Killian paper, and that is that those in Rett syndrome who by body mass index criteria were either overweight or obese had earlier pubic hair and breast development, but no change in the onset of menstruation. Clinical severity, as those of you who come to a clinic that use the clinical severity score or MBA, CSS or MBA, which is the CSS is the numeric predictor, if you will, or measurement of clinical severity. So a milder clinical presentation, so a lower clinical severity score was associated with earlier breast development and menstruation, but no change in pubic hair development. And we don't have answers for why these things occurred. This is just how the data bore out. And milder mutations were associated with earlier menstruation, but there were no change in pubic hair or breast development from across mutation types. Parents almost at this, even predating puberty signs, start talking about, well, you know, as in typical fashion, you always get your ducks in a row, and so you want to talk about menstrual management. And there are some very good, there's some information that you can investigate and some options that you can consider as you make this very personal decision about what to do. Some families choose to let nature take her course, and that means just not intervene on any level, and that may be because, you know, it's your approach to the issues that I listed on one of the first slides of hygiene and discomfort. You know, you feel like you've got a pretty good handle on, or else they're just non-issues. And it may be that her periods are not very problematic. Seizures aren't a problem. Hygiene isn't an issue, and so that you just don't find any reason to intervene. There are a number of hormonal methods that you might consider if you do want to manage menstruation on some level, and then there are surgical methods, and we'll talk about these in detail one by one. So why might you consider menstrual management? So I've touched on these: hygiene, comfort, safety if you are worried about abuse and pregnancy. It might minimize other health conditions like seizures, but you have to consider some other things as you are considering the method or whether or not to intervene. There might be side effects and health implications to your choices that you might be considering, as well as legal implications. And I said conservatorship, but I believe I meant guardianship. Are you able to make medical decisions for her, such as surgery, or even choosing a birth control method from the hormonal side? And then you have to be prepared to navigate the legal system if you are considering, say, for instance, a hysterectomy. That's not just necessarily an easy choice. You have to go through oftentimes the court system and prove that you are not taking away her rights to of pregnancy, if you will, and making this choice for her. So the first method that we'll talk about is the most common. It's the oldest. It's the birth control pill. I sometimes when I say birth control pill, I see a father tale. So sometimes I just call it an oral contraceptive. And these are typically estrogen progestin combination pills. You can use them either in what we call the old-fashioned way of taking them every day for either 21 or 28 days and coming off every month to have whatever type of period that you might have, or 90 days, so you would have potentially some period every quarter, or 365 days. There, in the last 10 years, a pill was packaged and formulated and advertised that was and ordered in that way. So it's a pill called Librel that is written for 365 days. Otherwise, there's nothing magic about it. It's just a lower estrogen form that can be taken every day, and it's written in that way, so you don't have to fight with insurance companies to pay for more than 12 packs. If you take just a typical birth control pill for 365 days, it can be done, but just know that the physician has to order it, and you may have to justify it with your insurance company to have more than 12 packs. I think it comes out to either 15 or 17 packs of real pills, not the placebos, over the course of a year. And there's no physiologic reason to have a period, so taking them in this way is from a physiological standpoint is just fine. And there's even now a chewable option if your daughter won't swallow a pill. There is a chewable option of one brand name is called Ovcon 35. And I won't read through this entire slide because you can certainly read this for your own. But one reason their use sometimes is to stop the hormone fluctuations that cause the seizure, so it evens things out. But there are pros and there are cons, and pros may be that it decreases the cancer risk in some individuals, but it also there's some important cons: increased risk of deep vein thrombosis or a blood clot in those who are non-ambulatory, and then the lower dose may cause breakthrough bleeding, and that's not really a con, but it's something I want you to know about because you may get frustrated and say, well, this isn't working. Here she's had, a period for 3 weeks out of the month, and this is not what we signed up for. And just know that you can that does tend to get better with time. I don't intend for you to read this slide, but it was just to demonstrate, and this is an old slide, so I haven't been able to find it in this format, but this is an illustration of all the different name brand oral contraceptives that are out there. And so, if one doesn't work, then, or you don't like the side effects, then there can be one that you might like better. So if you get, if you find that things are not working well, then just be sure and talk to the physician, tell them, or the prescriber, tell them exactly the problem with what you were, with the prescription that you were, that your daughter was taking, and see if there's one that might work better. And then there are the progestin-only oral contraceptives, also known as the mini pill. And they may work in the same way to regulate periods. They might reduce cramping. They're a good option for individuals who have migraines where an estrogen-based product is contraindicated, or in someone who is at higher risk for deep vein thrombosis, maybe someone who is in a wheelchair and not up a lot, moved around, sits sedentary most of the day. But there are some cons as well: mood swings, irregular bleeding, acne, tenderness, headache, ovarian cyst, and weight gain. The patch, such as Ortho-Evra, is an option. It's an estrogen progesterone combination preparation. It's placed on the different parts of the body and can be moved around. You might have periods every month, but it may reduce the flow and cramping. We don't know what the long-term effects are in those with developmental delays. There is more estrogen exposure because being a patch, it has to move through the skin barrier, and so there is that risk of deep vein thrombosis again because it is an estrogen-based product. An IUD is something that I had never really considered as a good option for women with Rett syndrome, but more and more it's being discussed by gynecologists and adolescent physicians, medicine physicians, as in fact a good option. And we actually have follow in our clinic here a few women who have used this, whose families have opted for this choice, and it's tolerated very well. It is placed in under some sort of sedation in the uterus by a physician or a nurse practitioner, and is effective for 5 years. It, in fact, may reduce blood loss and pain, but and in addition to preventing pregnancy. It's a good option when where estrogen isn't tolerated, either as side effects or as comorbid conditions such as deep vein thrombosis. But it is their insertion may be difficult in those who are small or who haven't had children, and there are risks of perforation. Depo-Provera injection has been around. It's one of the old methods for birth control, if you will, and many girls in the beginning of my experience with Rett syndrome came to us on this method, and it is an injection that's given every 3 months. Also regulates periods and protects against pregnancy. But we have, as we've learned more about the issues with bone density in those with Rett syndrome, we became very concerned, and rightly so, about the effects of Depo on bone density, and perhaps not even reversible bone density issues. Completely reversible when on this method. And so, since there are other methods that don't have this same issue, and this is not it reduces bone density in everybody who takes it. It just, or uses it to some degree, but it's just, that's already an issue in those with Rett syndrome, and we just feel like it complicates things when we have other options. It also can cause very heavy bleeding and irregular bleeding, significant behavior changes. I've been told by people who have used this, who could give me how they felt, could tell us how they felt, and it just made you feel like you want to jump out of your skin. It also can cause significant weight gain, unhealthy amounts of weight gain that have been proven to be very difficult to get off once that happens. So we recommend strongly against use of Depo-Provera. Vaginal rings are also in an effort to tell you everything that's out there. I put it up here just so that you know that it is out there. I don't know of anyone who has used this, but I just wanted you to be aware of the pros and the cons. So in 2010, the WHO looked at the type of hormones as they were recommending the use of those hormones in individuals who were having surgery, either that was anticipated with had prolonged immobilization in bed for a long amount of time, comparing to those who would have surgery without prolonged immobilization. And so on the left you see the different types. So combined oral contraceptives, patch, ring, progestin only, pills, Depo-Provera or implants, and then the IUD. And if you take this table and then make this be fit into into our population, so surgery without prolonged immobilization is equivalent to those who are non-ambulatory, then you can see where the WHO would consider an oral contraceptive or something with estrogen as an unacceptable health risk, and then going down the line of risks and recommendations in that group. Now we have plenty of girls who are in wheelchairs who take oral contraceptives, and I can only say that I know of one person who they felt like had a deep vein thrombosis that and who was also on a birth control pill, and they, it was hypothesized that might have contributed. So it's not that it's not an absolute that you would need to not consider that as an option, but certainly take measures to make sure that she is up and around, position changed often, hydrated as well as possible, and look for the signs of that being redness and tenderness on the leg, to make sure that DVTs don't progress or develop. There are surgical interventions such as endometrial ablation, where a wand is introduced through the cervix into the uterus, and by methods such as laser or freezing or heat, the endometrial lining is destroyed. It may be, depending on the age of the person, it could actually be permanent if the person is older. Then the endometrial lining is usually thinner than in a young pubescent woman, where the lining is usually very thick and healthy. Then it may not be a permanent fix. So it is a surgical procedure. We would recommend that it be done inpatient in order to manage complications in pain, although some physicians would do that outpatient in their office. We would recommend against that for a lot of different reasons. There are risks of lacerations and burns. I've a few years ago attended a conference in Boston that was about this very thing, about menstrual management and birth control in adolescents, and with a breakout session in individuals with developmental delays. And they recommended against this method because they said if for some reason you have to go back in and look at and do some sort of surgery for polyps or something like that inside the uterus, the anatomy, because of scar tissue, may look very different, and they are at a higher risk then of complications from removing that polyp or cyst from inside the uterus. The other type of surgical intervention might be a hysterectomy, either total or subtotal, complete removal of the uterus, the cervix, fallopian tubes, ovaries, or maybe only just the uterus and keep the cervix and the ovaries intact, which means the hormones would that the ovaries produce would still be produced, and so you might still have PMS or any fluctuations that might cause a lowering of seizure threshold. You just wouldn't have a menstrual cycle, a flushing of that endometrial lining. So it is an inpatient surgery. It is most often done under general anesthesia, and there are many techniques that can be done, both laparoscopically or full abdominal incisions. The pros to that is that it's permanent and complete, but the cons are the major surgery risks. Recovery time might be significant, and the legal implications are there as well. The relationship between seizures and oral contraceptives and anti-epileptic medicines there's a great relationship between those all of those situations, and we know that seizures may increase during puberty because the anti-epileptic drug levels may be adversely affected, so lowered either by fluid retention, if it's significant, rapid weight gain that you may see from entering puberty. Remember, I said that sometimes that's the first thing you see, and so the blood levels may be low, and not kept up with the milligram per kilogram dosing that we try to do, and then oral contraceptives may have an effect on anti-epileptic drug levels, and I'll talk about that a bit more. Hormones may fluctuate. Fluctuations may cause seizures, and I'll show you that in a bit. And then we know that poor sleep may lower the seizure threshold, and that sleep is often disrupted during periods, and so that may also affect seizures during puberty. We know that women with epilepsy are 4 to 7 times more likely to have irregular cycles, and that's just in general population, not haven't pulled out that data in the girls in natural history study with the epilepsy, but we know in the general population this is true. So it may be very necessary to keep a seizure and menstrual cycle diary if things become less predictable than they've been in the past before she started her menstruating. So there is this relationship between seizures and hormones. Hormones influence seizure occurrence. So estrogen is excitatory, has an excitatory effect on brain cells, and that might equate to an increase in seizures. And progesterone has an inhibitory effect on brain cells, and that might equate to fewer seizures. And then seizures that are associated with ovulation or menstruation are called catamenial. It's called catamenial epilepsy, and those are caused by hormone fluctuations. So we're going to look at our diagram again of the days of the cycle. And remember, we talked about how if you look at think about the previous slide, that estrogen is neuroexcitatory, and so one time that you might see a uptick in seizures might be when that estrogen level or estradiol is at its highest point, which is right before ovulation, maybe between day 11 and 12. And then remembering the slide again that progesterone is neuroinhibitory. If you want to think about or look at the time when progesterone is on its downward trend, and the estrogen in blue is not at its all-time low, then you might say another point of when seizures occur would be right before the periods at approximately day 26. So this is again in a perfect cycle where things are happening at 28 days as they're supposed to, when you would say that ovulation is occurring about mid-cycle. There are some catamenial epilepsy treatment options that you might consider, or your physician might consider, and that's either adjusting the existing seizure medication once you know you've got a good blood level during seizures. You might also consider adjusting them up a bit during the cycle that you have that you are able to predict with some certainty by keeping that seizure diary and that menstruation diary. There are also some methods, of intermittent perimenstrual medications. So right before menstruation, some people choose to start clonazepam or clobazam, either one, and these are just some dose recommendations that might be used. And then you might consider some sort of hormonal manipulation, the oral contraceptives, either around the calendar or progesterone only during certain days of the cycle. Some literature recommends. And then there are diuretics that are not, I wouldn't say frequently used, but are used by some of the epileptologists, particularly Dr. Glaze at Baylor has used Dimox as a particular diuretic that is that's effective with seizures, and then sleep medications perhaps to improve that quality of sleep if it's only an issue during at some point during the cycle. I want to tell you about the effects that oral contraceptives may have on anti-epileptic medications. So specifically, they might decrease levels of Lamictal or lamotrigine, which may result in an increase of seizures. And so you may need to, if your daughter is on Lamictal already and you're considering starting an oral contraceptive, you may find that a higher dose of Lamictal all of a sudden may be required, and that's not necessarily a bad thing. It's just that that's if you're going that route, then that may be something that may be required. But in that regard, if it may also be a good argument for that 365-day oral contraceptive pill or menstrual management pill called the Librel, because you won't have that fluctuation of Lamictal when you come off of between the active oral contraceptive active or placebo phase, or even the week that she's off to have whatever period she's going to have. So if you've increased the Lamictal for the times that she's on oral contraceptive and all of a sudden she's not taking the active pills, then the Lamictal level could shoot up and cause toxicity. or result in toxicity of lamictal. So a more even state throughout the calendar would be advantageous. Oral contraceptives, conversely, might increase levels of dilantin, phenytoin, causing toxicity. So it would be prudent to have drug levels done after estrogen therapy is begun if your daughter is on that seizure medicine. But the oral contraceptives seem to have no effect on Depo-Provera or Tegretol. Also, conversely, anti-epileptic medications may have effects on oral contraceptives, making them less effective. So what you might see is breakthrough bleeding. And this, I'm not going to read this list, but these are these 6 meds may do increase the breakdown of contraceptives. And so just be aware of that. And then the next point on this slide is that these medications seem to have no effect on oral contraceptives. I want to talk for a bit now about menopause. And you might say, well, why is this relevant in Rett syndrome? Well, it's relevant because we know from our natural history study, specifically the survival and longevity data that was published in 2010, that at age 50, more than 50% of the girls or women are surviving, which is great news. Earlier in some of the old literature, erroneous literature, said that that survival was much shorter. But this means that we really have to think about health issues in women of middle age, if you will. And we also have to know if the periods stop, is this pathology or menopause? And when your daughters might not be able to communicate with you, or if things are so irregular for whatever reason, you have to figure out, if you think about our Marge Simpson diagram again, is there something that's happened from top to bottom that's causing this change, or is it the natural progression of menopause? And what have we observed in our women with Rett syndrome? Well, we don't have a whole lot of data, but anecdotal observation and reports suggest an early aging in appearance. So gray hair may be before you would expect to see gray hair, maybe slowing in their how fast they get around, how interested they are in being active, but we're not sure what the impact is on the age of the impact of having Rett syndrome has on menopause. And so that's why these big question marks, we don't know. And that's why enrollment of women of all ages in the natural history study is so critical. Menopause in general, just to give you some idea, if you are too young to really understand or be thinking about menopause, the average age in the general population is around, and this is in the U.S., around 51 years, usually occurs between 48 and 55. Premenopause means that you're somewhere in the neighborhood of in your early 40s, but less than 45 with no symptoms of menopause. Perimenopause means 45 years or greater in age, and your periods have become irregular. And postmenopause is greater than 45 years with no periods for 12 months, or less than 45 years when your ovaries have been removed and the change in hormones has been confirmed by blood work. So what are the health issues that everyone should or faces, not just those with Rett syndrome, but all of us in menopause? Osteoporosis, and you know how we are concerned about that, and it is confounded not only by just virtue of of menopause, but also in if you're non-weight bearing, so unable to walk or stand. If you're on long-term anti-epileptics, some of those increase the risk of osteoporosis as well. Mood changes, hot flashes, increased chance of bladder infections. So it would be, one of those things that you might consider if your daughter, as a menopausal age person, or is obviously ill, then that would be it wouldn't be unusual to have to need a urine specimen to rule out a bladder or urinary tract infection. Abnormal bleeding is not uncommon. Whether or not to use hormone replacement therapy is a personal preference. It may be given to offset symptoms such as hot flashes and bone loss, but they do come with their own risks, such as breast and endometrial cancers. What do we know about women who are going through menopause and who have seizures? And this is from a study published in Epilepsia in 1999. And whether or not this bears true in Rett syndrome, we don't know, but we would expect so. Many women report changes in their seizures during menopause. So either changes in their seizure frequency or type, or maybe the first onset of seizures might occur during menopause. Of those who had seizures prior to menopause, 41% reported that their seizures worsened. A few reported, or a quarter of those who had seizures prior reported an improvement, and about a third said they reported no change. 20 of those who first experienced seizures, 20% first experienced seizures in menopause, and some of those were for unrelated medical reasons and couldn't be contributed to anything other than having a stroke or a brain tumor. And then what are the hormone replacement therapy effects on seizures? 13% reported they made them worse, 16% said they made them better, and 71% reported no change. Let's talk some about health maintenance. One of the first things, and of course, these are outside the other considerations. These are just womanhood health maintenance issues that I'm going to talk about today. The others are a whole nother talk about how to maintain health throughout life in specific things in Rett syndrome. But I'm going to touch most specifically on breast health and gynecological health in the next few slides. So one of the things to consider about breast health in a woman is what family history. Is there a family history of breast cancer? And if so, those are reasons to be particularly vigilant about breast health. What's the living environment? Not to say residential care would be less attentive, but and they actually may be more attentive if the parents are elderly and worried about their own health and trying to care for their daughter also at home. But you have to consider what the living arrangement is and how attuned are they going to be to changes in breasts. So some of the signs of a problem in breast health would be a lump, of course, we all know that, or maybe even a hard or a flat area on the breast. So you really have to observe those. And usually the best time to do that is during bath time, but it might also be as you are changing her to put her in bed at night. There may be nipple changes in size or character, and there may even be a discharge from the nipple. change in a size, contour of the breast, texture of the breast, or even temperature, and then swelling in the armpit. So, we hear it's harped on a lot how important breast exams are, and that monthly breast exam is something that we all are supposed to do on ourselves, but you're going to have to consider doing this, and that's why I put self-exam in quotation marks, because the self-exam becomes caregiver or parent exam, and this is even more important because she may not be telling you other symptoms that she might be feeling, such as, tenderness or something of that ilk. And then an annual physician exam, not necessarily. You notice I didn't put mammogram. It's all I can do to psych myself up to go in every month or every year rather for this. I can't imagine explaining this to your daughter, but that would be something though to considering a family history or risks that your physician and you might have a discussion as trying to decide exactly what the best vigilant screening is. Then there are gynecological problems that might happen, and amenorrhea means the absence of menstruation. So that may be primary, meaning a structural abnormality. So maybe there's an imperforate vagina. Remembering that I said the problems with development might be structural ones in the vagina. That means that there's the opening between the uterus and the vagina is closed. The opening is not there, and so that would be something that it's rare. It's very rare, but it's something to keep in the back of your mind and to remember that no periods again are not necessarily a good thing. And then secondary reasons for amenorrhea may be a physiologic problem, or maybe onset of menopause, or maybe pregnancy. Vaginitis, which is an inflammation, infection, or irritation of the vaginal area, and that may be caused from yeast or bacteria or an STD. Fecal sources can cause vaginitis. So if she is uses diapers or is not, hygiene is not great as far as cleaning her up after a bowel movement, then that can contribute to vaginitis. Antibiotics can cause an overkill of good bacteria and an overgrowth of yeast, and may cause a vaginal infection that can be uncomfortable and itchy and stinky. Intercourse can cause vaginitis. Bubble baths can also cause vaginitis. So if your daughter likes bubble baths but yet has frequent vaginal inflammations, you may have to leave those off. And then damp and tight diapers or underwear are a perfect environment for a yeast infection. So frequent diaper changes are a good thing. Diapers used to be, you changed them. They didn't used to be so absorbent, and now it's easier to sit in them longer because they absorb so well, but it's not a good environment for vaginal health. Other problems might be vaginal bleeding that's abnormal. So it could be premature or precocious puberty. It could be because of trauma. Some bad vaginitis infections, vaginitis, can cause bleeding as well. It could be a forgotten tampon. It could be some other structural problem like a prolapse or a tumor. Other pains, other gynecological problems might be pain from endometriosis, and that is, I understand, horribly uncomfortable, and might be cause for some sort of surgical or pharmaceutical treatment, medication treatments to control endometriosis. And then, of course, carcinomas. And these are not all of the problems. They're just some of the ones to keep in mind. And then I want to just touch upon vaccinations for human papillomavirus or HPV. And why would you do that? Well, it's because HPV is the most common cause of cervical cancers. And when would that be considered? Well, it's considered if you're sexually active, including non-consensual sex. And in this country, Gardasil is the trade name that's the most common vaccine given. It's given. We try to give it in preteen girls between 11 and 12, and then later on if they didn't receive it as a preteen up to age 26. I can't say that I know girls with Rett syndrome whose parents have opted for this, but there again, it's something that I want you to know about and consider and make an informed decision about. It's given as a shot, 3 doses over 6 months. It's not a pleasant injection. My daughters received it, and I'm not going to lie, it's not very comfortable, but it's necessary. But why would it be necessary if they're not sexually active? Well, in the situation of sexual abuse. Whether or not to have a gynecological exam in a special population is a real conundrum for all of us. And I don't have an answer. I don't have a definitive yes, it needs to be done, or no, it doesn't. So why would you consider it? It's because we would say that all individuals should be treated equally, that everyone should have the same access to health care as everyone else. But you have to weigh the risks of the pain and the discomfort of that might occur during an exam, and why would that be necessary if they're not sexually active? Well, medical history would influence that. Some people would say if you choose to use hormones, some physicians say then I feel like I wouldn't be doing my due diligence if I didn't make some sort of evaluation as I'm prescribing hormones to get a baseline and to make sure that I'm not doing something to cause harm. And then a gynecological exam detects more diseases, more than diseases associated with intercourse like HPV. So there are more things to consider. But whatever you do decide, then the care around that gynecological exam or not, the care needs to be individualized. So the pelvic exam, there are 2 methods that if you will. One is considered the sort of the gold standard or the typical speculum exam, where the speculum opens up the vagina and allows visualization of the cervix and collection of cells, a good visualization of the cervix and collection of cells for a pap smear. You can request a smaller speculum. It's not one size fits all. They can be torturous to endure, as we all know, but you can request that smaller speculum. And discharges from the cervix or the vagina can be collected to take a look, as well as that look of is the cervix open. But then there is what we call a bimanual exam, so the use of 2 hands rather than a speculum. It's gentler, but it might in some situations be less effective to see into the in all the way up the vagina and look at the um, cervix. But the clinician uses feel by pressing up with the hand inside the vagina and pressing down on the abdomen. They can feel for abnormalities of the uterus and ovaries and sometimes even the rectum. There are also alternative positions other than stirrups that I will show in the next slide, and you can perform a pap smear without a speculum, but it is more difficult. So other positions for the pelvic exam might be these, such as a knee to chest, a diamond shape where the legs are put together, the feet are put together and the legs are opened up, a V shape, or an M shape when the knees are bent and up. And so you can see that these are much simpler, if you will, than having someone up in stirrups, and maybe even less traumatic and frightening. If you decide that a pap smear is the route you want to go for your daughter, just to make sure that everything is all considerations are out there. There are task force. There was a task force in 2012 that put together the most recent guidelines, which are in some ways broken up either by age or by condition, such as a hysterectomy with no cervical cancer or risks of other high risks such as organ transplants or HIV or medication exposures. And so I won't read this because you can look for yourself, but there are recommendations that go along with ages. So how do you prepare for a pelvic exam for your daughter? Well, the first thing you do is to do your homework to find a caregiver or healthcare provider, rather, who is a right fit. And that might be an adolescent medicine physician, a nurse practitioner. You might ask your own GYN about who they recommend, or other families who are going through, maybe have made this path before you. You might choose to have some sort of pre-exam appointment or conversation where you would discuss things such as the use of sedatives, and for her, not for you, but you might need it too. And then what type of room and equipment accommodations they're able to make for you or are available for you. There are some practices that have tables that are lower and then raise up to the level that they need to be for the exam, so that it's not necessary to lift her up and onto a table. What type of exam they're going to do? Bimanual versus a speculum, or are they going to do a pap smear versus just taking a good look-see? And then, are they open to alternative positions? And are they going to require a guardianship for you to make decisions about what to do with the information that they give you during that exam? You need to anticipate what their questions are going to be. So gather the family medical history. Put together the menstrual calendar, particularly if you're going for some sort of problem, description of the cycles, whatever symptoms she's having, what medication she's on, and prepare. Prepare yourself, prepare her by talking with her, reassuring her, letting her know that you will be right there, and encouraging her along the way. And what are the responsibilities as you go in to consider this exam? Well, for you, it's to give a thorough and accurate history. For the physician side, it's to perform the most thorough exam with sensitivity that addresses the symptoms. Both of you should give explanations. Don't talk over her. I know, sorry, pardon me. I know that you don't. You understand that she understands you, but you may have to remind the clinician to talk to her, not over her, and to offer her support. Consider sedation. It may make her more relaxed and certainly more comfortable, and congratulate her once it's over. Tell her that she was very brave and that you know it was not comfortable on any level. In the last few slides, I'd like to talk about are unfortunately things that I wish I didn't have to talk about, but that are necessary for you to know, and that's safety and sexual abuse. It can and does occur at any age, but it's foremost in our minds when our daughters reach puberty. And these are some of the unfortunate facts that have been identified. Children with disabilities are almost twice as likely to be sexually abused. Among adults who are developmentally delayed, as many as over 80% of females are victims of sexual assault. Regardless of age, race, ethnicity, sexual orientation, or class, women with disabilities are assaulted, raped, and abused at more than twice the rate of non-disabled women. So what does this mean? This means you can't have your head in the sand. As much as you say, I know where she is, I know who's with her, I know I'm very vigilant, I've picked good places for her to be, there's a good chance that that this will happen. Over 90% of abusers will be people you know, trust, and regularly encounter. Family, neighbors, babysitters, service providers. So you have to know that this is what can happen. You need to have conversations with her where she communicates with you however way is her way. If you've noticed that something's not right, if the environment in which she's in is new, if she, and I mean by environment is new, I don't necessarily mean that she's in a different place, but are the people around her known to you? Do they have a history? Are there people that you are comfortable with? And even if you are comfortable, if she tells you that something is wrong, either by communicating verbally or non-verbally, that things are not right, then you need to start investigating and take her to a physician or a clinician that can help you figure out if, when everything else has been ruled out and all of the reasons for a change in behavior are there, is this something that you have to consider? Now, take a deep breath. We are done with the hard stuff. Remember to be positive. She takes her cues from you. If you are and are anxious about puberty or menopause or an exam, then she's going to pick up on that. So you have to be calm. Accept that that physical maturation is normal, and recognize her full potential as a maturing individual. This is her right to become a woman. She's fought hard to become a woman, and you fought hard to keep her healthy as a healthy 50-year-old. And so this is the rite of passage. And you have to know what's normal in order to recognize abnormal. And that's critical to keep in order to keep her healthy and safe. And that's all I have. Paige, do you take it back over?
I do. Sorry, Jane. I was on mute and couldn't figure out how to get to my screen to unmute. I'm sorry. Okay.
Okay.
Thank you very much. I really appreciate the slide for everyone to take a deep breath and appreciate so much your willingness to tackle some really deep, hard stuff, but it is really important information, as you said at the very beginning of your presentation, that without information and knowledge, we can't be the best advocates that we can possibly be for our kids. For those of you who are on the call who are younger parents, I hope that you take this information, tuck it away until the time that you need it. And for those of you who are parents of young women and older women, that this information has been really relevant and eye-opening for you. So the presentation today was very heavy on medical information and statistics from the natural history study. Thank you so much, Jane. We will be setting up another webcast for some discussions around quality of life and family scenarios, what happens in adulthood, and I really look forward to that panel conversation with some parents who have been there and are going to be sharing their experiences. We'll let you know that date when it comes. We have a few minutes left for our presentation, and we have a few questions that have come in, Jane, and I'm wondering if I can go through those questions in these last few minutes.
Sure.
That would be fantastic. So I think you touched on a lot of these issues in your slides, but it's really what's on everybody's mind. So let's do some kind of a round of speed dating. If we don't get to all of the questions that have been asked in the queue, Jane and I will spend some time getting them answered. And again, we will prepare a QA document that will be posted on the website to pair with the recording from today's call. Okay. So first question in the queue, Jane, is it normal to have a 22-year-old daughter with Rett syndrome who's never had a period except when given medications from her gynecologist?
So the first three words out of that sentence was, is it normal? And the short answer is no, it's not normal. It's not normal in the general population, nor is it normal in the Rett population, even knowing that we have outliers with delayed menstruation. Now, you know, the bigger question, or the bigger question to answer, is why. So is that a problem with hormone production? Is that she's just so thin? We know that and I didn't have time to show that slide, but there are many reasons or many variables that come into play with puberty and menstruation, one being genetics. But as far as, you know, are you going to start and is your pattern going to be similar to your mother's, or is it because of that you're so thin? Because we know that there's a correlation between the amount of body fat and menstruation. These really elite athletes that are, you know, have 4% body fat or 10% body fat stop menstruating because they're just so lean and they don't have that body fat. So the answer is no, it's not normal, but the important question is to get at that I would want to know as a parent, and I'm sure the physician knows why, but just to figure out why it is that that injection is needed to have a period.
Okay, thank you. Jane, let me do a quick time check with you. I know you have clinic today. Do you have the ability to stay on for a few minutes for us to get through some more questions?
Okay. Yeah, Judy's covering clinic for me.
Okay, wonderful. So we are at the time that we promised to wrap up today, but we have a few important questions for those of you who'd like to stay on. We invite you to do so, and let's take a few more minutes, Jane. Okay? Thank you for having the time. Next question is, I found it very interesting, the slide, and thank you for pointing out the number of years that can span between the onset of signs of puberty, like smelly armpits, and the actual onset of menstruation. So we have a question: can girls have hormonal or catamenial seizures without having yet started her period?
I don't have the data for that, but I would, just from anecdotally, from what we've seen in clinic leading up to that, it's not like all of a sudden one day, the hormones start being produced. It's gradual, and that's why you start developing secondary sex characteristics. That 10 or 2 begins, quite early and or a number of years before menstruation. And so what I imagine happens is that when seizures, we do see an uptick of seizures before menstruation is actually seen. What I imagine is happening is in the background, the hormones are being, starting to ramp up and rev up, and that's why we see that uptick. It also might be because they do start putting on some weight right as they prepare for puberty, and so it may be that the levels are just not keeping up with their weight.
Okay. Follow-on question is if someone has a daughter who has not had seizures or epilepsy in the course of her having Rett syndrome, is it likely or is it possible that she could just start having them around the time of puberty?
It is, yes, it is possible. It's at any point in a girl with Rett syndrome's life, there is the chance that she has a seizure, and I don't have those data in front of me exactly what the percentage is, but we do see an uptick right before, as a new onset seizure, right before during puberty. That is one of the times that that seizures might appear, but by the same token, they seem to level off, and maybe even the EEG may even improve as they get older. So while there may be an uptick during puberty, or there may be a new onset, just be heartened that may improve as they get older.
Okay, great. Thank you. I wanted to share a comment that a mom wanted to really thank you for emphasizing how normal periods are, and that it really bothers her to see families making the choice to stop having periods just because they're messy, and for you to have given such a nice explanation of the reasons why and the side effects. She just wanted to thank you for that.
I try to be even-handed.
Okay. So we have some parents who are facing the transition from school to adult daycare and adult-style care. And they're wondering if you have any recommendations of ways to help ease that transition, and some of the things that you cautioned they might be presenting. Are there things or any papers that you've written or recommendations to help with that transition, to educate the caregivers and care providers at the adult facilities?
No. I mean, I think that that RettSyndrome.org has such as the adulthood access online that is there. The handbook has some things in it. I think that the advice that I would have, I have lots of advice. One is to start early. Don't wait until she's, a junior in high school to start finding a place, because it's that's going to put some pressure on you, not only to find the best situation, but to get on the list. And as she ages, you may be too. So you may be facing health issues of your own that would keep you from going around and finding the perfect place for her. So I would say start early. I would say trust your instincts. If you go in and I would visit, as much as you think you can do without them, when they would still let you in to look, I would go early and often and look around. I would see the composition, if you have some options. That's just common sense. The place where if there are younger individuals, then that's going to be the place that your daughter likes the most. I would, rather than in with, geriatrics, if that's, but if that's all you've got, then that may be what you have to be content with. I think thinking outside the box with residential, setting up a residential facility of your own, and I know you just go, yeah, right, but we have a family from Chicago that taught us so much about how they set up their own residential home with 3 or 4 or 5 other families that they had gotten to be friends with during high school. And so it's not as expensive as you think it might be to do that. And so think outside the box and make it, to see if maybe that's something that would work for a group in your area, so that you might feel better about knowing who she's with, and in a place that you've not only handpicked, but that you've had some help with. And then I would say maybe reach out, see if you can find early, caregivers from earlier in her life. Maybe there's someone who's tired of working in a classroom, and maybe they would be interested in being a one-on-one, more like a peer, rather than in a big or a bigger day care program.
Great, thank you. And as I mentioned, we're going to be setting up a future webcast where we're going to invite some families who have made this transition to share their stories, and perhaps we'll get that family in Chicago to join us.
Yep.
Good situations. And I'd also like to remind everyone that you will be getting a recording of the session, and you can share that recording with all of the care providers in your child's life, regardless of her age. And so that you don't feel responsible for bringing up this difficult situation or casting any doubt, but just it's our responsibility to be the best advocates we can be for our girls. So let Jane do the talking. When you get the recording, you can fast forward to the parts that are most relevant and most on your mind. Let someone watch it, and then let them tell you what they've done to minimize these risks and help care for your daughter in all aspects of her life. Okay, let's see, I've got 2 more questions here, Jane, that I think are most important, then we'll wrap up. And as always, if anyone has any questions after the session today, you can certainly reach out to me and to Jane at any time. This is not a one and done scenario or situation. Okay. Jane, one point in your talk, you referred to the clinical severity chart, and a parent is asking where they can see that, or if you can talk just a little bit more about that.
Well, the clinical severity scale has been around for a number of years. It is, I don't have it in front of me. It's something that the clinicians, I think it's, I'm trying to think, maybe it's a 30-point scale, maybe 25-point scale that considers when when her regression was, does she still walk and talk? Does she have seizures? Things like that are, and then there's like I think a 4 or 5 point scale for each question, and they at the end they tally it all up, and based on the history or on what they observe in clinic during the evaluation, they tally it all up, and it gives a numeric clinical severity impression. And it's used, we used it in clinic for a long time, but it's been most useful in the last few years with the advent of the clinical trials that are here as an outcome measure. Have we actually made things better or worse with clinical severity by the treatment compound? It's not perfect, and it's sort of a work in process, but it's at least was the best impression at the time, and we do still use it every day. So that is something that we can certainly share. It's not privileged information. Matter of fact, it's probably published somewhere, and I can't put my finger on it right this minute. But I'm happy to, Paige, I don't know the best way we can upload that with everything else. We can, however you think, I'm happy to share that.
Yeah, thank you. I think it was included in the revised diagnostic criteria paper that was published. Mm-hmm. I believe, yeah. And if not, if any of you, if you're enrolled in the natural history study, I'm sure at the time when you go back for your next visit, you can discuss it with the investigator that you're with for the natural history study, and they can show you the charts and go over it in more detail. And Jane, you and I can work and see if we can get those and get them posted, as we do. Mm-hmm. We get a lot of questions about what we mean by clinical severity, mm-hmm. and what those charts look like. Mm-hmm. Okay, so the last question I have, again, this is like speed dating, right? The questions are all over, but I think this is a nice one and an important one to close. And the question is, do you have any suggestions on how to best transition from pediatric care to an internal medicine doctor for someone who's totally unfamiliar with Rett syndrome?
Well, in the perfect world, that it wouldn't just be something that the parents are responsible for making happen. So in a perfect world, when your daughter turned, say, arbitrary, 13 or so, you would start talking to your pediatrician about what the transition plan is. And don't be lulled into complacency by that pediatrician saying, "Oh, don't worry, I'll continue to see her," because a lot can change in 5 years, both in that person's ability to, still be around, or in the practice of themselves. So the practice, if you're not in making independent decisions, the rest of your partners may say, "No, we're not doing that." So you start an early conversation, and then if you were lucky enough to be in an area close to a medical center, typically they have physicians that are called MED peds. So those are physicians that have double boarded, and they have in pediatrics and internal medicine. So they have the advantage of understanding adult health care issues. They have privileges at the adult hospital, but yet they have trained as pediatricians, so they understand and are not afraid of developmental disorders or small adults in size, those kinds of things. And so if I had, in the perfect world, I would say find a med peds. Have your pediatrician help you find a med peds. If you don't have that advantage, then you just start you start early, and you know, if you don't like the first person that you go to, then you say thank you very much. We'll look elsewhere. Um, if another perfect world is that the pediatrician would help you make that transition by telling the internal medicine, I won't see her anymore, but I will help you. I will help you through your questions. Just call me, you know, and we'll make this transition work by me having your back until you're comfortable. I think that the other thing to do is to not be avoidant of well visits. So you can't expect someone to know her if they only see her when she is ill. And so that not only is health maintenance for vaccinations and whatnot important, it's also important so that they understand what she looks like when she is well, and that when she's hyperventilating and breath holding, that's not something that's abnormal. That's her normal situation, or when she wrings her hands, or whatever it is. So those would be things that I would say. Get information from other families, get information from your pediatrician, and start early.
Great advice. Thank you. And as I mentioned, Katie's 15, so I'm right in the thick of it. If anyone has questions about this process, again, please let us know after the call today. And Judy Barish, who's the nurse at the Bluebird Rett Center, has also written a very nice blog for us on MedPeds physicians and programs, and goes into a little bit more depth on that subject. So I think it's about time for us to wrap up. But again, this doesn't conclude our conversation. It is continuing and ongoing at all times. But Jane, we really appreciate your time. Thank you so much for taking a special interest into this, really what is a wonderful period of life and stage of life as our girls move from childhood to adolescence into adulthood. As you so eloquently said, they have fought hard for the rights to age, and we support them in that whole process. And your information really empowers us to be able to do that support even more sensitively and more adequately. So thank you so much.
My pleasure.
We invite you to get online again to rettsyndrome.org/RettEd and look at the calendar for the rest of the year on the topics that we have planned. Next month on April 10th, we welcome Dr. Kathleen Moteal, who is going to discuss common GI issues, how to intervene, clinical research that's underway. And I know that is a really welcome topic for conversation. So please go ahead and register for that talk. To all of our attendees, I hope you found value in today's session, and that the knowledge that you learned from Jane will help you in ways great and small in your path forward. Continue conversation on social media sites, on RettNet. I know a lot of the conversation that we have is the how-tos and what-ifs of the personal care and hygiene of our kids, and that's wisdom that is nicely shared often and frequently between parents, both mothers and fathers, and others who are care providers for our young girls and women. So, I just wanted to underscore that at rettsyndrome.org, we believe that all information should be free and accessible to everyone who avails themselves of it. So please take the recording of today's call, share it with those in your child's life who may need to be further educated on any of the topics that Jane covered. And we want to really thank our supporters for allowing us to bring these types of webinars to you. And by doing these webinars, we're also able to direct more precious dollars towards research, helping with the care and cure of our girls. So please stay connected with each other, with our experts, and we look forward to seeing you again next month. Thank you, and this concludes today's RettEd webinar.